give folks a few more minutes to join, and we will be beginning promptly at 3 p.m. Eastern Time. Thanks. Thank you, everyone who's joined us today. We're going to get started in about 2 minutes, promptly at 3 o'clock. Just wanted to draw your attention to the slide that's up with some housekeeping rules. You are muted upon entry. Please remain muted in an effort to reduce background noise. Throughout the webinar, we will have the Q&A feature, which can be found in the bottom toolbar. And we ask you to please submit all your questions for speakers through that Q&A feature. And we'll get started in just a minute. So I have 3 o'clock on my phone. I do think we're going to get started. My name's Becky Russell. I am the Senior Director of Applied Research and Evaluation at the National Institute for Children's Health Quality, or NICHQ. A few housekeeping rules before we get started. You have been muted upon entry. Please keep your lines muted throughout the presentations so as to reduce some background noise. We will have some time, hopefully at the end, for some discussion and Q&A, but at any time throughout the presentation, you can enter your questions into the Q&A feature, which you can find in the toolbar. We will be providing a recording of the webinar that will be shared with everyone after the live event that will be posted to the NICHQ website. So again, welcome everyone to today's webinar, Reducing Preterm Birth, States Share Interventions, Policy Efforts, and Emerging Issues. As I said, I'm Becky Russell. I'm the Senior Director for Applied Research and Evaluation at NICHQ, and it is truly my pleasure to moderate this webinar today, which is World Prematurity Day, and a time when this work is really just as important as it ever has been. We saw new report cards released by the March of Dimes this week that have shown that the preterm birth rate in the country is continuing to go up. And so this work is really even more relevant today. I imagine that many of you on this webinar today are familiar with and were even involved with the work that was done at a national and state level as part of the infant mortality CoIIN, which was a national initiative to improve birth outcomes and decrease infant mortality rates. We've been very fortunate at NICHQ with funding from the Robert Wood Johnson Foundation to really be able to take a deeper dive into learning about some of the specific state strategies that were adopted during IM CoIIN to address preterm birth, which is a leading cause of infant mortality. So we've been very pleased and happy to be able to work with the Robert Wood Johnson Foundation. Jamie Bassell, who's the Senior Program Officer and Childhood Obesity Lead at Robert Wood Johnson, has been our project officer, and we're so happy to have her here today on this call, and just want to give her an opportunity to say a few words.
Great. Thanks, Becky, so much. Really happy to be with all of you today. So the foundation was thrilled to be able to support this work, whose aim was really to identify and elevate best practices, strategies to impact preterm birth, infant mortality, and maternal health and well-being. As part of the Robert Wood Johnson Foundation's ongoing commitment to building a culture of health, and more specifically, some of our new work related to birth justice and gender equity. I hope that the really powerful insights from this work will help spur and inspire action and application across the states, with great potential to reduce preterm birth, infant mortality, to support the health and well-being of moms, and ultimately eliminate the deep and persistent disparities that continue to plague our nation, as Becky alluded to. I'll just close with a really special thank you to all the families who so generously shared their incredibly personal stories. And of course, all of the partners across all 4 states, Kansas, Massachusetts, Mississippi, and Oklahoma, for their really thoughtful reflections. And then finally, a big thank you to the incredible team at NICHQ, who I've had the great honor of working with over the last couple of years. So with that, I will turn it back to Becky.
Thanks, Jamie. Again, so pleased that you're here with us today. So before we jump in, I think we could go to the next slide. I am just going to quickly introduce everyone to NICHQ for those who may not be familiar with who we are and what we do. For over 20 years, NICHQ has focused on driving dramatic changes in the complex issues facing children's health. We focus on change management, which we do through working with multidisciplinary teams of health experts, community partners, practitioners, and families, and we work to define the problems and then design data-driven strategies that deliver sustainable impact. We've seen tremendous success with this approach over the years, with projects focusing on a number of different issues, from infant mortality to breastfeeding to sickle cell disease and many others. Next slide. Central to our mission is the vision that every child achieves their optimal health, which places equity central in all of the work that we do. Our agenda for the next hour will be to provide you with an overview of the infant mortality CoIIN. Then you'll hear directly from 3 states on their work, and we'll wrap up with some key findings and recommendations coming out of this work, and hopefully leave about 10 minutes at the end for our discussion and Q&A. Today's speakers are just an amazing panel that I am honored to have been able to work with them. Scott Burns has served as president and CEO at NICHQ since 2015, where he applies his extensive experience working across academic, clinical, nonprofit, community, and public health settings to lead initiatives aimed at driving change to improve children's health. Dr. Burns is a nationally recognized expert in quality improvement science in maternal and child health and has published extensively. Dr. Burns is also co-founder and board chair of the Progeria Research Foundation, where he ensured that PRF was a key force behind the progeria gene discovery and has developed impactful international programs for progeria families and researchers. In addition, he currently serves as chair of the Patient-Centered Outcomes Research Institute's Rare Disease Advisory Panel. Prior to joining NICHQ, Dr. Burns spent 14 years at the March of Dimes National Office, serving as the Senior Vice President of Chapter Programs and the Deputy Medical Officer. He provided direction in education and community services to all March of Dimes state-based chapters, including the District of Columbia and Puerto Rico. Dr. Burns is a board-certified pediatrician and pediatric emergency physician. He's a clinical professor of pediatrics at the Warren Alpert Medical School of Brown University and clinical professor of health services policy and practice at the Brown School of Public Health. Dr. Burns has also completed a 1-year White House fellowship where he served as a senior advisor to the U.S. Secretary of Transportation. Rachel Sisson has more than 20 years of experience directing and managing public health programming. She currently serves as the Kansas Department of Health and Environment's Bureau of Family Health Director. The Bureau coordinates and oversees many of the essential public health services and programs community-based partners provide for women, infants, children, and families in Kansas, such as maternal and child health, family planning, WIC, Part C early intervention, childcare, and more. Rachel also serves as the Kansas Title V MCH Director, oversees administration of the federal block grant and implementation of the state action plan, programs, and services. She holds a master's degree in early childhood education and bachelor's degree in family studies and human services from Kansas State University. Next, we have Charlene Collier, who is a board-certified OBGYN and is the director of the Mississippi Perinatal Quality Collaborative and State Maternal Mortality Review Committee. She is an associate professor of obstetrics and gynecology at the University of Mississippi Medical Center and serves as a perinatal advisor for the Mississippi State Department of Health, leading hospital and community-based initiatives to improve maternal and infant health in Mississippi. She completed medical school at Brown University and obtained a master's in public health from the Harvard School of Public Health. After OBGYN residency at Yale New Haven Hospital, she was a Robert Wood Johnson Clinical Scholar at Yale, earning a master's in health science. She's an executive committee member of the National Network of Perinatal Quality Collaboratives and a member of the Obstetrics Practice Committee of the American College of Obstetricians and Gynecologists. Audra Meadows is a birth optimizer. I love that. She cares for women before, during, and after pregnancy to ensure positive pregnancy and birth experiences. As an obstetrician and gynecologist, Dr. Meadows actively investigates strategies to prevent preterm birth and maternal morbidity and to eliminate racial and ethnic disparities in maternal health and birth outcomes. In her roles as assistant professor and faculty at Harvard Medical School and the Brigham and Women's Hospital, Dr. Meadows has taught medical students, residents, and fellows, and devoted time to prenatal care practice innovation and advocacy. For more than 15 years, she's been passionate about achieving health equity and creating value in clinical practice. She implemented group prenatal care into the BWH OBGYN residency practice to better serve those pregnant and parenting. Dr. Meadows has served as medical director of the BWH ambulatory obstetrics practice, the Boston Healthy Start Initiative, and the BWH Stronger Generations program. She has worked with the Institute for Healthcare Improvement and the National Quality Forum to address birth equity through quality improvement and continues to lead the Perinatal Neonatal Quality Improvement Network of Massachusetts. She is currently a Robert Wood Johnson Foundation Interdisciplinary Leaders Research Scholar, an NIH-funded researcher investigating strategies to prevent maternal morbidity and achieve equity, with a particular emphasis on including the voices of those pregnant and parenting in identifying these strategies. And now I'll turn it over to Dr. Burns to get us started. Scott?
Thanks, Becky. Thank you, everyone, for joining us today, and a special thanks to all of you who have been involved with the infant mortality coin, the IM coin, over the years. This groundbreaking and innovative project is one that has had a lasting impact, and it will be great to hear from 3 of the states a bit later today. With NICHQ as the coordinating center for IM CoIIN between 2013 and 2017, it was a privilege to work alongside the national, state, and local stakeholders with a common goal of reducing infant mortality. Next slide. Why did the Maternal Child Health Bureau, MCHB, decide to focus on infant mortality? Many of you already know that the US has one of the worst rates of infant mortality of all industrialized countries. This is important as infant mortality is one of the key indicators of the health of a nation. Next slide. When we look at that numbers, when infant mortality coin launched, the infant mortality rate in the US was 5.96 per 1,000 live births, which is more than 23,000 babies who died before their first birthday. This number was simply unacceptable. Next slide. To address this national tragedy, the federal government launched a bold initiative, the Collaborative Improvement and Innovation Network to Reduce Infant Mortality, IM CoIIN. Next slide. More specifically, the infant mortality coin set out to do the following things: produce measurable improvements within 12 to 18 months among states in identified strategy areas or learning networks, set out to also increase synergy among state health officials, maternal child health directors, and state and national public and private partners around evidence-based strategies to reduce infant mortality and improve birth outcomes. It set out to lead and collaborate with others to help communities strengthen resources that improve outcomes. And it also set out to improve health equity by reducing disparities in quality of care and access to care across populations and communities. Next slide. 51 states and jurisdictions engaged in a state-led process to identify the strategic areas of focus that would become the learning networks of this coin. NICHQ and MCHB encouraged states to pick one, but no more than 3 learning networks to ensure focus and ensure proper resources. Beyond the strategy areas listed here, the coin further expanded to include family and consumer representation, leadership from our clinical partners, and collaboration from the local level up to the national level, with ongoing opportunities to connect and learn from each other. Next slide. The results were remarkable. Per the Secretary Advisory Committee on Infant Mortality's recommendation at the beginning of the initiative, we aimed to see a 3% annual average reduction in infant mortality. The 5% decline seen during the IM CoIIN was promising and suggested that we could, in fact, accelerate improvement, with some states seeing an even larger reduction. Nearly a third of states experienced a decline of 10% or more. Next slide. Preterm birth, a major contributor to infant mortality, also saw improvements. When IM CoIIN ended, the data showed that preterm birth rates were going down nationally and in nearly 70% of states. Next slide. So, what were the keys to the success of such a monumental call to action through 2017? They're listed here. To summarize, the structure of the infant mortality coin was important. I'll come back to this. A national call to action, a technical assistance hub, an information technology infrastructure, and the use of quality improvement to move the needle forward. Next slide. The structure, the national call to action. It was so important. I love this slide. This slide is from about 3 years ago now, actually just over 3 years ago now, from the final presentation that NICHQ gave at the Maternal Child Health Bureau at HRSA in Rockville. And it was so important to engage the right partners to create a national movement. We leveraged NICHQ's internal expertise and brought nationally known experts and faculty to support core methods implementation. For example, Tara Bristol, who's on the slide, was brought on to help support NICHQ's commitment to engage patients and families in all of our work. So to me, the legacy of that 4 years really, it brought us another challenge, but we certainly have carried on, meaning that I remember after that day in Rockville, we all got together and chatted, and a lot of the folks on the slide here, and Vanessa Lee, our project officer, we were talking about, gosh, we've really engaged the right folks. How do we keep the momentum going? I mean, we brought these national organizations together. We worked on a common agenda towards a bold shared goal. We allowing innovation and improvement science to drive the work. And we felt this camaraderie that was just so important to continue to push the movement forward. Next slide. So what's happened since then, since 2017? Next slide, some more data. To show you, 4 additional infant mortality focused coins were launched in 2017, and they were focused on safe sleep, social determinants of health, preconception care, and early prenatal care. And infant mortality rates for the country overall have continued to decline, as you see in this slide. And in fact, just this week, as Becky mentioned, actually yesterday, the March of Dimes released their annual report cards for 2020 for the nation and for every state. While the nation's infant mortality rate has continued to decline, preterm births, next slide, have increased for the 5th consecutive year. While there are some things we do know about the increases, like the fact that most of the increase has happened among late preterm births, those born just a few weeks early, and that the increases are happening across all racial and ethnic groups, we do not yet fully understand the causes of these increases. Next slide. The work that was done during IM CoIIN and the lessons we can still learn from this effort is just as important today as it was 7 years ago. Despite improvements in infant mortality, we still have a public health crisis of racism in this country that has resulted in Black babies dying at twice the rate of white babies. with rising preterm birth rates, increasing disparities, and a pandemic that is changing the way we provide access to care. Learning from the states is critically important, which is why we're here today, critically important to devising strategies for how to address the underlying factors impacting the health of moms and babies. We undertook this work that you can hear more about now with the funding and partnership of the Robert Wood Johnson Foundation, and we deeply appreciate our project officer, Jamie Bussell, who you heard from, who values the important learnings from the IM CoIIN. With her support, and as summarized here on this slide, we sought to learn and understand how states are addressing challenges through systems, policies, and other factors, and also to develop local, state, and national recommendations to address rising preterm birth rates. I'll turn it back now to Becky to get us started with the state presentations. Becky?
Thanks, Scott. As Scott described, our goals in this work really included looking at the states for solutions and opportunities, focusing on their IM CoIIN strategies, but also hearing from them about what has gone on since IM CoIIN and what they see as needs and priorities looking forward. Each of the 4 states that we selected participated in the 2013 to 17 phase of the infant mortality CoIIN and elected to address preterm births as one of their priority areas. In order to have a diverse set of states, we determined and included additional criteria for state selection, which included, among other things, a representation of different areas of the country based on HRSA regions. We wanted states that had a high level of program engagement and data submission capacity during their IM CoIIN participation. And we also were looking for high levels of engagement of the State Perinatal Quality Collaborative. And then also we were interested in selecting states that had variability in their Medicaid expansion, as we know how much that has driven improvements in access to care. We wanted to be able to look at states that were varied in their expansion of Medicaid. So to do this work, we conducted site visits from June to September 2019, and we contacted the state team leads from IM CoIIN and asked them to identify key stakeholders to participate in a series of focus groups over 2 days in each of the states. Through those focus groups, we really allowed us to engage with stakeholders and dig deeper and ask probing questions related to their state-specific risk factors, innovative solutions, and more. Participants included a diverse set of stakeholders in each state, including local and state health departments, state hospital associations, local March of Dimes markets, WIC offices, Healthy Start programs, social service agencies, and Medicaid offices, just to name a few. It was really quite an amazing experience to travel to these 4 states and to be able to talk with all of those stakeholders. Today, you'll get to hear from 3 of the 4 states. Unfortunately, Oklahoma could not be here, but I encourage you all to take a look at the case study, and we'll make that link available to you at the end, and really learn in that case study, read about their innovative approaches to partnerships, their statewide initiatives to address early elective deliveries, some of their amazing local programs and targeted initiatives to address birth spacing and long-acting reversible contraception. Just an amazing set of stakeholders that we met with. They welcomed us to Oklahoma, and they provided insights into their work and their challenges, and shared with us their challenges and solutions. So please be sure to take a look at the case study. So with that, I think we will go to the next slide. We'll hear from Rachel and the great work that they've been doing in Kansas. So Rachel?
Hi, thanks so much, Becky, and special thanks to NICHQ and RWJF for the opportunity for Kansas to participate and share today. Next slide. I'm going to talk about a bright spot today, our Kansas Perinatal Community Collaboratives. It's really what CoIIN helped us get organized around, and it continues to be one of our best and strongest investments. Next slide. First of all, I really want to just set the stage so that the community collaboratives and the continuous investment in that birth outcomes model is better understood. Because we wouldn't be where we are today if not for the structure and the organization and the intense work around the infant mortality CoIIN. So Kansas signed on in 2014, and we formally closed out the CoIIN project in 2017. And these first couple of slides really provide you with the context for where Kansas's focus was related to strategies. we were participating in the pre and early term birth learning collaborative, as well as the smoking cessation network. So as I talk a little bit about our work, you can see the detail on this slide. I wanted to highlight that we were following the driver diagrams and the strategies around the IM CoIIN. We wanted to increase utilization of progesterone, so we leveraged existing partnerships in the state, specifically Optum Health, also known as Alere Health. The 3 managed care organizations in Kansas already had contracts with Optum Health and were paying for OB home care services, and administration of progesterone for women that were eligible for that was a part of that service. So we partnered directly with MCOs and Optum and looked at areas of the state where they were administering the program and engaged public health, primary care, and all other partners around increasing the communication with patients, and then really getting providers engaged in administration of 17P. We also utilized public health and maternal and child health home visitors across the state, because home administration was really important when you think about the population and the needs. We also wanted to increase access to smoking cessation programs. As I said, we were a part of the pre and early term birth learning network, as well as smoking cessation. So these two related networks were really important, and we were looking at improving smoking cessation in Kansas, especially in the Medicaid population. So as part of the IM CoIIN work, we came up with a smoking history form, which was somewhat of a smoking use screening form. It was improved over the years as we were engaged in the IM CoIIN. We ended up tracking cessation rates and followed up on asking and documenting when a patient quit. We also developed a smoking cessation toolkit. We directly invested using maternal and child health public dollars in partnership with our tobacco program. We provided training on baby and me tobacco free directly to sites across the state. We also provided training on script and provided thousands of materials for our partners to get started. We also promoted the quit line. It was the one evidence-based intervention that we really had to leverage across the state. Baby and me tobacco free was implemented in 10 communities. We have 5 that are either still implementing baby and me tobacco free with the national program or have a modified approach. The quit line was really important. There were tons of webinars and tips on how to utilize that more effectively, refer, follow up, and then increase success with quitting. Integration toolkits were a big part of our CoIIN work. Over the years, we not only created the smoking one, which turned into a tobacco cessation toolkit, but we have many of those integration toolkits now that our partners rely on that are kind of grab and go around many topics. I'll share more on that later because it's important to the bright spot. The bright spot really focuses on the birth outcomes model, and the main thing that we utilized to integrate everything that we did around infant mortality CoIIN. The CoIIN timing was critical for Kansas, and I would say all Title V maternal and child health programs across the nation, because we were in the midst of a statewide needs assessment at that very time. And in 2015, we finalized our state action plan for the period 2016 to 2020. It was our plan for sustainability and for long-term impact and gain around IM CoIIN. So everything that we were doing basically around IM CoIIN was integrated and embedded within our maternal and child health state action plan. That's what led to ongoing investment and a comprehensive approach to leverage everything that we did for CoIIN. We also ensured that we had data collection. You know, Becky mentioned capacity to collect data. We have MCH epidemiologists, but we knew we needed a system if we wanted to have long-term impact and monitor the success of our quality improvement and tests for change. So we built and launched a shared data system that we continue to use today for all of our local programs and partners. Next slide. This is just a quick look at the policy side. So we just discussed a little bit about strategy, but it was really important that we followed up with policy changes where necessary. We focused in on using our outstation workers and presumptive eligibility for Medicaid to get pregnant women connected to coverage right away so services could be accessed. We worked on hard stop policies and ended up having our non-medically indicated early elective delivery rate go from 4% to less than 1% in just a few years through partnerships. We also partnered with March of Dimes on the 39 weeks banner recognition program to really highlight and elevate those that were we're seeing success and following through on policy change. We looked at reimbursement for progesterone and changed that, ensured that home visiting and public health was a part of that service delivery. We promoted LARC, as I said, and developed an integration toolkit, but we heard from primary care providers that and OBs that they weren't inserting after delivery, and some patients weren't coming back for the postpartum visit. So we wanted to make sure that it could be paid for outside of the hospital and unbundled from the DRG or that delivery payment. We looked at public health as a really important setting for screening for tobacco and providing interventions. So public health is now a setting that can be reimbursed for that tobacco cessation counseling. And then of course, since 2010, the Clean Indoor Air Act, Tobacco 21 in 2019, we continue to utilize those in Kansas and draw on those important policy changes. We also continue to work together to try to enhance the quit line. Pregnant women receive more services through Can Quit than any other individual participating. We've also integrated support for e-cigarettes. Next slide. Okay, so getting to the good stuff. Next slide. As I said in the beginning, we really needed something from a long-term standpoint related to maternal and child health to integrate everything that we did for CoIIN to ensure that when CoIIN as a formal project ended, the Kansas work didn't stop and that we could continue even monitoring our success. So in 2014, when CoIIN had just started, we partnered with the March of Dimes to formalize the Becoming a Mom curriculum. And you can see on this slide generally what it is. There's a nice description there. It really brings together prenatal care, education, and wraps supports around pregnant women and families at the community level. Next slide. So you've got the curriculum. And like I said, that's a March of Dimes program. And we had started to see really great outcomes from that as early as 2010 for our communities that were utilizing it. We partnered with March of Dimes for the state health department to really start to spread and scale that approach and develop supplemental materials and resources to really create a model, I would say, or an approach that became known as the Kansas Perinatal Community Collaborative. And those collaboratives utilize the March of Dimes curriculum. So there are two core components: cognitive, which we address through 6 prenatal education sessions focused on prenatal care, pregnancy, postpartum, and infant care. So the infant health development period. And then also behavioral. So we really promote healthier behaviors, mom with herself, within the family, how she cares for herself, her pregnancy, and infant care. Next slide. So usually when we talk about the model or the program, it's about an hour to do the presentation. So I'm just highlighting for you some core components. I think it's important for everyone to understand that we've been working on implementing this program since 2010. KDHE, the state health department, and maternal and child health really started overseeing it in 2014 to spread and scale. So it is standardized, it's really important. However, we meet communities where they're at. So there are many opportunities to modify, keeping with fidelity.
Rachel, we have about 1 minute.
They have to complete training, sign an MOU, and deliver with facilitators and capture the data. Next slide. So this is a list of those integration toolkits that I talked about. Over time, since the IM CoIIN, we've developed many integration toolkits that are worked into the model. So hospitals, FQHCs, public health departments, OBs, or private practice, everybody's working together in the collaborative. And these are ways that we addressed important issues at the community level. All the resources are embedded. Next slide. This is not meant to be read. It just kind of shows you what our strategy and approach is. So how do we determine where to focus these collaboratives? We look at disparities in birth outcomes, preterm birth specifically as a driver, as well as infant mortality. We also look at concentrated disadvantage. So this is how we decide where to focus efforts. Next slide. This is a quote from a participant. Basically, you can read it. You know, this feels really supportive. We have 85% of participants that rate an excellent experience in the perinatal quality collaborative work at the community level. Next slide. So what are we finding from this? Like I said, we have a shared measurement system and we have a formal evaluation at the state level. So this really shows you that we're reaching the targeted population, right? Racial ethnic minorities, lower education, they're younger, they're non-private, and they're usually in WIC. Next slide. Also, you can read the slide here, but the focus is they're very likely to report talking to their provider about preventing pregnancy after the birth of their baby, after attending the sessions and learning more about what contraception is right for them and the importance of safe inter-birth spacing. Next slide. Okay, again, some rates. So what we want to focus in on here is the birth outcome for becoming a mom or perinatal collaborative participants is about 4.9% when you look at preterm birth compared to 9.5% for the state rate. There's some other findings there that are really important that you can look at on the slide related to breastfeeding, low birth weight, and cesareans. But I think we really want to focus on infant mortality. This is what we're seeing in Kansas. And we started to see these changes 3 to 4 years after communities were implementing this model. Geary County and Saline County, both rural areas, established in 2010 and 2012. Next slide. And that's really the end. I just wanted you to know that we have a public website where you can find a lot more information, and then a private portal for all of our communities. They have to sign the MOU and take training, and then they have access to all the materials. We spent the last 5 years really building up governance and ensuring that we have the infrastructure so ready communities can move quickly. Next slide. That's my contact information. And Stephanie Wolf is our public health nurse, and Stephanie oversees the perinatal community collaboratives and is working on spreading and scaling now.
Awesome. Thank you so much, Rachel. That was great. If we can go to the next slide, I'm going to quickly turn it over to Charlene Collier to talk about Mississippi's efforts to address preterm birth rates.
Thank you, Becky, and that was an amazing presentation, Rachel, and I hope those are some ideas we're going to borrow from Mississippi, which was such a critical component of the CoIIN, was being able to steal shamelessly from other states. So that's something I hope we can use from Kansas. So thank you so much. I'll be presenting a little bit. NICHQ asked me to talk a bit about our strategies in Mississippi to address health equity in preterm birth. And I remember my initial reaction being that we didn't address equity, which was a weird response, but I realized the reason I felt that way initially is because our perception of equity in 2020 is very different than where it was at the beginning of the CoIIN. Equity today definitely means directly confronting the root causes of disparities, and that's being racism and the structural inequities that have been driven by racism in our state. And that was definitely not where the conversation was when we were initially part of the CoIIN. We were very focused on health disparities. But of course, we did address equity. It was just kind of taking a moment to recognize where we have evolved from when we were addressing those issues related to preterm birth, looking at those disparities and trying to bring our strategies to the populations who are affected by those disparities, but we were not actively looking at the root causes of those disparities, at least not here in Mississippi, where I can tell you where I just moved to this state, pull up at the State Department of Health where the Confederate flag was flying out front, and I was one of the few leaders on the team who was Black amongst other public health professionals who were white, and not really sure if it was a safe space to talk about those issues. So we absolutely were all together in on trying to reduce Black preterm birth, but it was from a very different perspective. So I kind of wanted to just reflect upon that and make note of that before sharing what our overall equity response was, in fact, during that time. Next slide. So this, as folks mentioned, the March of Dimes report card came out this year, and Mississippi is once again has the at the bottom with the highest preterm birth rate in the nation at 14.6%. Like nationally, our rates are going up, largely driven by a decline in our overall births. And thankfully, we are not also seeing an increased rate in infant mortality. Next slide. And this, of course, is the biggest and persistent story in our state, with Black mothers giving birth preterm at a rate of 16.7%, 43% higher than white mothers. And again, I remember conversations back in 2012 and 2013 and hearing people say, well, our rates are higher because of demographics. And the conversation would end there, as if the higher percentage of Black mothers in Mississippi is what explained our higher preterm birth rates. And of course, this is not the framework we would at all accept, and we really should never have thought about it being race that drove these differences, but really beginning to look and recognize racism. However, this is where we stand in the biggest, one of the biggest issues we do consistently confront. Next slide. So when we were addressing infant mortality, of course, we were looking at these were the particular topics that were looking most at preterm birth. And within each of them, we were focused on how can we make this effort benefit those who are at greatest risk, which was Black mothers and babies in our state. So next, you can hit the button again. So for each of the issues, so for increasing access to 17P, we looked across our state, really mapped out where progesterone was being prescribed and where it wasn't, where were the populations with highest risks of recurrent preterm birth, and found that many practices were not stocking 17P. Many mothers were having to drive over an hour to get to their OB provider. We have large, what we call OB deserts here in Mississippi. And what the program we devised was really a great one, where each of our local health departments was becoming a distributor for progesterone, and at that time it was compounded. But once the FDA ruled that practices could not or should not use compounded when there was McKenna, that program quickly came to an end, and we had to shift towards working towards price reductions and working with our insurers to make McKenna more accessible. But the women who really suffered most in that shift and change was definitely our rural women, particularly in the Delta. But that is something we were ever conscious of. With the respect to tobacco cessation and our baby and me tobacco free, we have established that in 11 different community health centers across our state, really focusing in the areas that have both an intersection of high tobacco and high preterm birth rates. We did not just look at higher tobacco use in pregnancy, because there were some communities, particularly with white communities on the coast, where the tobacco use was higher, but their preterm birth rates were not higher. And so we really wanted to work directly where we saw the greatest need, and those programs are still in existence today. And then with respect to risk appropriate care or perinatal regionalization, and this was really focusing at getting moms to deliver or care for at the risk appropriate location. So if babies were born preterm, they can get optimal care. This was a difficult issue in Mississippi, because the places with the greatest need were often those that did not have truly functioning level 3 NICUs. And the approach wasn't going to be to go into those communities and tell them, no longer practice. The only answer was to stop using those services and move more mothers to urban centers. We really took it from the approach of how can we build capacity in these areas? How can we build greater support to the practices and providers, and really help to break down the silos between NICUs in our state, so that actually more coverage was provided to increase the capacity at local hospitals, as opposed to really just diverting families away from their local centers of care. Next slide. Some of our policy efforts, CoIIN definitely led the way in terms of establishing a reduction in early elective deliveries. We first also did the March of Dimes banner recognition program, and our state private insurer was the first to adopt policy changes for hard stops, and then our state Medicaid. And I really always think of policy as being a true driver of equity, because you don't see piecemeal adoption of best practices. It's one way to really ensure that all mothers and families get access to the best care. So we always have a policy objective insight when we're working on these projects. We shifted tobacco control from the state to the local level. So local communities actually received funding to develop coalitions to address tobacco use in ways that they saw fit to build in sustainability. And we did not expand Medicaid in our state, so that was probably one of the greatest harms to health equity that we could still have to deal with, but we did make efforts to streamline coverage for pregnancy services. And lastly, we were making sure our Title V programs were funding those efforts that were directly going to impact the communities that needed it most. Next slide. One of our proudest efforts was our Sisters United program, which was directly borrowed from the Arkansas program. And this was really most promising because it really did make an effort centering Black women and mothers in the efforts to reduce preterm birth. It was a partnership that was with historically Black colleges and universities and working with Black sororities across the state. And it was a train the trainer model where we really worked with those sorority leaders to develop what the messaging and interventions were, and then they would go and teach in their own communities and hold events. And the focus areas with Sisters United were a little different from the CoIIN of what we heard back from our participating mothers and families, and they wanted to build awareness about preterm birth risk in the Black community. Many women were shocked to find out about the disparities, and also address things like chronic health issues, obesity, hypertension, and those were also not issues originally covered in the CoIIN. And that along with SIDS and SUIDs and breastfeeding. And this was a program we really had hopes of scaling up and spreading, and we saw this as having the most promise because we really saw those who were implementing it to share it in their churches, their communities. It was at the graduate chapter level, the college level, and so it stopped after the CoIIN, but we're really proud to say that this is a program we'll be bringing back this year with Title V funds, and really our sororities are ready to jump right in and take this on again. But it did teach us a lesson in really listening to the communities and women who are going to benefit the most from the efforts about how we shape our strategies moving forward. Next slide. So this is a quote from a family interviewee, which we thought was really powerful, and someone saying, I want to make people aware that African-American women are still facing racial biases and have a lead multi-sector approach to help drive change as it relates to this crisis. So this family member was really able to hit the nail on the head that when asked about preterm birth, they were able to recognize that it was bias, racism, and discrimination that needs to be dismantled, not just looking at particular strategies around the issue of preterm birth itself. Next slide. So participating in the CoIIN was really invaluable for Mississippi. It completely provided us with a structure and framework for moving forward for improvement, created collaborations across states that we still make use of today, and really allowed data to be now at the center of our work. But we definitely wish we could have, led with what Black mothers and families wanted from the outset. Next slide. And again, now looking forward, as we address our disparities, we're really going to be placing more focus on racism and dismantling the impact of that in both prenatal and perinatal care. Centering maternal health, when we looked at our actual preterm births and the causes, we saw maternal hypertension is causing up to 1/3 of our preterm births in our state, and seeing increases in preterm births related to substance use. And we want more data and patient-family measures. In particular, we're not going to just take preterm-related infant deaths for granted, but we're going to really begin reviewing those cases, much like we do with maternal mortality review committees, where we can really gather information from medical records, family interviews, and see where the opportunities for improvement are. And we truly believe that is in patient and family stories that we will find where our improvements need to be. So again, I really thank NICHQ for this opportunity, and look forward to continuing to work with all the other states on infant mortality and preterm birth in the future. So thank you.
Thank you so much, Dr. Collier. We're going to turn now to Dr. Meadows to discuss Massachusetts.
Thank you, everyone. This is a really great conversation, and I really appreciate the comments of the two former speakers, because I think what's important is to look at their data, and that the data shown just how high some of the rates of preterm birth are, as well as the rates of infant mortality. Next slide. And in Massachusetts, we have a little bit of a different story. We've had ridiculously high rates in certain cities in Massachusetts, but overall, the state of Massachusetts often is hailed as one of the states that has some of the better rates in terms of lower infant mortality, lower preterm birth. Though I will say there is no such thing as an acceptable number. We do know that there's no acceptable number of infants that die before their first birthday, to Dr. Burns' earlier comment. With that, we have seen some successes. During the period of IM CoIIN, we were able to see that mortality rates continue to decrease in Massachusetts, and they have increased just a slight bit with the new information from the report card. Next slide. As we've seen, part of that is in part the infant mortality rates lowering is due to the decrease in preterm birth rates. With that, we've also seen on the report card that in Massachusetts, that some of those rates have started to go up again in those cities that we recognize that have some of the higher rates, and those include the city of Boston, which has a greater population, also a greater percentage of people of color living in that particular city. In the center of Massachusetts is Worcester, that has higher rates, and then out farther west, there's Springfield. And so we have these 3 cities that we've often focused on across the state as we've done this work. Next slide. What we're really great, and this slide talks about some of our targeted interventions, and what I really want to say about our work in Massachusetts is that IM CoIIN helped to really galvanize all these groups of people who were doing work in their smaller pockets and working in silos. And so one thing that we've all experienced in our work in public health is that there's lots of silos. And so we've been able with IM CoIIN to break down those walls and truly form this one collaborative group of providers with a broad range of expertise of stakeholders to really do this work toward preventing preterm birth and reducing this infant mortality number and eliminating it where we're able to. And with that, we've been able to progressively move forward and continue to work together. And so some of our attention has gone from specifically looking at preterm birth prevention and to Dr. Collier's point, to looking at equity and looking at more systems level engagement, system change. So things that we tended to do were broaden the provider engagement in our state PQC, which is called PINQUIN, the Perinatal Neonatal Quality Improvement Network of Massachusetts. And that network is a life course approach organization, or PQC, where we're looking at equity, but anything that we're working we're also looking at where there's the neonatal component, and we can bring in our pediatric and neonatology colleagues to that. We also at one point looked at expanding group prenatal care practices across Massachusetts. We really dove into that really nicely in those major cities that I just mentioned in Massachusetts. And one thing that was important in the gains there was that many providers began to understand and recognize ways that they could practice medicine differently so that it could really improve outcomes, because we all know the definition of insanity is doing things the same way and trying to get a different outcome, which we've all been working to get a different outcome over the years. And so with that, we've also been able to raise awareness for women that there is another way to receive prenatal care, either individually in a group or in a hybrid model of individual and in a group. And for some women that led to greater successes for them. So we did a pilot project specifically within Brigham and Women's Hospital to look at women who engaged in group prenatal care. And we were able to show some really important and positive gains. We know this national data that shows a lot of the same gains that I'm going to mention, but one thing that's really important is that women were really happy with their care. Next, women also had lower rates of cesarean delivery, lower rates of what we saw to be unanticipated NICU admissions, which was really an important finding that was also reported in the Carolinas and in North Carolina for a national state model. We also saw savings for the Medicaid, what we called the ACO plan for Medicaid. And with that, we were able to show that it's not simply just access to care across all of Massachusetts, which we have really high rates of women with access to care with insurance. What we really looked at was once women are in care, the kind of care they received, that there's a better model of care for some that we hadn't been offering prior to that. And so that was really important. In terms of increasing our statewide data collection, especially in our PQC, we've begun to focus really deeply on collecting data by race, ethnicity, geography, language, ability, trying to really get at that information that explains these differences in outcome, not only by the label of their race, ethnicity, or other demographic identifier, but really leaning into that data to understand what are the differences in the social determinants that we need to really address to get change, to be the positive change that we're looking for. Next slide. And so this slide just shows that we had a number of efforts from 2013 all the way through 2018, looking particularly at preventing preterm birth through progesterone and some of the work we put together from a policy standpoint, a clinical standpoint, raising awareness. But with that, next slide, we've been more interested in what are some of these policy efforts that can be sustainable and that can be expanded and that can really address women and their preconception, interconception, their lifelong health during the reproductive age timeframe. And with that, you will find women then having better outcomes when those policies represent a living scenario that doesn't represent the biases that we've seen through systemic racism, institutional racism, and especially even interpersonal racism. And some of the things that we were able to identify as really strong policy efforts in Massachusetts included the funding the Health Equity Initiative. We've had a few different programs for priority housing for women and children, increasing the state earned income tax rate, the Massachusetts paid family medical leave, and we've prioritized equity through our Title V block grant program for MCH. So some of that work has really led us into some appreciable gains. Next slide. We also took a strong policy stance on group prenatal care by working to encourage the state to offer enhanced reimbursement, and we know that's done in other states. We weren't able to be successful in that effort in Massachusetts, but with that, we've created a complete policy brief to help other states that might be working toward the same. Next slide. And one of our dads that participated in a program that I want to highlight next in Massachusetts, particularly in Boston at Brigham and Women's Hospital, is a dad that made a comment that said, do you wait for the people to ask for it, or do you set things up prior to people asking? And so with Stronger Generations, what we work toward is exactly that. And in Massachusetts, we've worked toward exactly that, setting things up prior to people needing to ask for it. So really having those policies in place to really address those issues of systemic and structural racism, to dismantle that so that we create an environment where everyone has equal opportunity to their best health. Next slide. So Cam was a participant in this program, Stronger Generations, where at Brigham and Women's, we created a program that looked at how do we help every child to have a lifetime of health that begins at their birth, and one could even argue that begins at their conception, because we work with the moms during their pregnancy or the pregnant person during their pregnancy to ensure that their health and birth experiences are optimized, and to the mission and vision of NICHQ, which I really appreciate, for having every child have a chance for optimal health. And so that's our goal. So this is the mission and the core beliefs. We do believe that every baby deserves the healthiest start possible. A lifetime of health equity begins at birth, and health is a human right. And so we want to and have worked to ingrain these core values and beliefs into the programming. And so the reason we highlight Stronger Generations and what Stronger Generations brings is a difference of a program that doesn't just address the clinical, is also a program that brings multiple stakeholders together so that we can collaborate in partnership, which is one of the really foundational reasons for the success of some of the work we've seen in Massachusetts. It also, though, incorporates this concept of community, where many of the areas that women engage in or that the families engage in Stronger Generations are in groups, so that when folks are working together on financial goals or their educational or vocational goals, some of that can be done in partnership with some of our advocates that are in the community, like a banking organization that would give a class for families and parents. And with that, doing that in groups so that we can bring those voices of the community together and have the voices of people who are receiving care from the hospital systems that we worked with tell what are the benefits of what's been set up and what are things that they're also looking for to help them have the best lives at home, so they can also have the best health and enter the healthcare system with the best possible start for their health as well. Next slide.
One more minute, Dr. Meadows.
Sure. And I want to also turn our attention to this idea now of, as we're thinking about these rising rates of preterm birth, we're looking at equity in Massachusetts. We're looking at equity through our state PQC. We also are hearing a little bit more about preterm birth rates rising in the era of COVID. And with that, we've seen the CDC report that birth and infant outcomes actually were not increasing. This is somewhere around midsummer when we just had information from March through May. And then we're now starting to see numbers and rates show that maybe preterm rates are going up from around that 9 to 10% to 12%. Next slide. And we have to think about what that means. And we know that, as we've been talking about through the last presenters, that this is also another area where we need to be thinking about leaning into equity and what are some of those systemic factors that have led to these differences in outcomes, especially for vulnerable populations. And so that's something that we'll be continuing to turn our attention toward in Massachusetts, and something that I think we should all be looking at across all the various states as we do this work to keep preterm birth rates low.
Great. Thank you so much, Dr. Meadows, and thank you to all of our speakers. I'm going to spend just a couple of minutes to speed through some of our key findings and recommendations from this work, and then hopefully we'll have 1 or 2 minutes for questions. I see you've been putting them into the Q&A box, and it seems like most of them have been answered, but hopefully. So as we were coming out of our site visits and we were reviewing the focus groups and the themes, I think what you can hear, many of these outcomes, it was really clear to us that while for some of the strategies that were encouraged as part of IM CoIIN, they may have been limited in their impact. And what we know about them has really changed. And so when we take that into account, we take into this sort of evolving landscape around preterm birth prevention, looking at the changing landscape in a post-COVID world, if you will. We have proposed a set of recommendations really based on those common themes and insights. So if you go to the next slide. To begin with, I just want to say national and state initiatives, our biggest recommendation was that they need to be intentionally focused on the social influences on preterm birth that so clearly arose from the case studies, as you've heard from our speakers today, addressing inequities in care and care coverage across all states, addressing bias in the structural and historical racism in healthcare systems, looking at the unequal availability of programs and supports that we actually do know to be effective are all critical pieces to us being able to look at and address the rising preterm birth rates. With or without effective clinical interventions, the barriers related to social determinants and equity really underlie and exacerbate the access and quality of care for women of color across this country, even in states that may otherwise be considered the best of the best, as we just heard from Dr. Meadows. Next slide. We have a set of national strategies that we feel are needed to permanently change the persistent contribution of preterm birth to infant mortality, and I'll let you read those, but I do want to just highlight one of them, which is that our language, our messages, and our programming really needs to move beyond talking about disparities reduction and addressing implicit bias, and more clearly focus on anti-racism and full health equity for all. So shifting how we recognize and change the impact of racism in America. I think we've heard that clearly today. We also need to be thinking about how we can build in accountability measures for anti-racism in the healthcare field. I think that'll be critical to any progress moving forward. We heard in every state innovative and promising programs, really lifting up those programs for others to learn and prioritizing their evaluation to understand why they work should also be a priority. Next slide. At the state and local level, also states, cities, and communities, they really have an important role and responsibility to recharge preterm birth prevention efforts. So looking at, we heard from states that need continuing efforts to examine their data, understand their populations, better target contributors to infant mortality in their states, really rebuilding plans where necessary, re-energizing those partnerships that were so meaningful to the IM CoIIN. I think it would be necessary for us to really move forward in these prevention efforts. And the next slide. I just do want to say you can read about all of the recommendations as well as the in-depth case studies in the publication that's available on NICHQ's website. We'll also put the link in the chat box for you there. And just finally, last, certainly not least, I do want to talk about the importance of the family stories to all of this work. We spoke with families in every state that had recently had a baby to hear their perspectives on the system. I think Cam's on the call today, who participated in the Massachusetts program and the case study, and we're just so thankful and grateful to the perspectives of the families and the fathers and the mothers to help us understand what we need to do to better serve those families and help ensure that every child can reach their optimal health. So with that, I know we are at the top of the hour. I think a lot of you did chat in your questions. I don't know if the speakers have time for just 1 or 2 questions. I think we had a couple. I'm not sure if the speakers are still on. Corey, hoping you can help.
I'm still here, but
Okay.
I know we're over.
Okay. Well, thank you all for chatting in your questions. I think we did answer them all. If not, please feel free to reach out to us and we will make the connection with the speakers. Thank you all for participating in today's webinar, sharing your questions. As we close, I do want to redirect you to the evaluation survey for this event. Take a few minutes to let us know what you think. Maybe a little better time management in the future, but just really welcomed the rich discussion that the panelists provided to us. So thank you all.
Thank you. Thank you.